Thanks, Win. So, um, I remember the first time I attended a Bangkok Symposium, I think back in 8 years ago. It was very clinical to the point where I couldn't find anything that I can relate to. And I'm so glad that we are really moving so fast in trying to improve our service and the care for our patient. So I'm just going to talk about mental health. Maybe it's something that you are already understand a lot, or some of you might have very little understanding, but I'm just going to give an overview of what is mental health and the syndemic and the determinants of mental health and HIV, and some of the screening tools that we have in the literature on screening mental health issue among people living with HIV or affected by HIV, and some of the consideration that we should bear in mind in selecting the tools, right? That's $1 million questions that Karin said. And I'm gonna show you some different types of different mental health integration model that has been done in a HIV setting, and some strategies that we can take home from the literature. And lastly, allow me to introduce the ID clinic in UMC from my country. So to start off, mental health is a state of mental well-being that enables people to build positive relationships with another person, help us to understand and manage our positive and negative emotions and cope with stressor in life, to carry out our daily function, our responsibility in life, and the last one, to realize our ability to learn better, to work better, and contribute to the community. And one of the take-home message here is mental health has an intrinsic and it has instrumental value, and is very fundamental to our well-being in life. And mental health is not a binary state where it is a yes or a no, meaning we are not either mentally healthy or mentally ill. It exists on a complex continuum with experiences ranging from optimal state of well-being to debilitating states of great suffering or emotional pain. So mental health is not defined by whether someone has a mental health disorder or not. Along the different dimension of the mental health continuum, mental health issue and challenges affects everybody differently. Meaning to say, you and I might be going through the same mental health issue in life, but we go through the process itself very differently depending on the individual. Yeah, this is very true, especially on the degree of difficulties or distress that someone's feeling. And the severity and the duration of a mental health condition varies from person to person. This figure shows the disability-adjusted life years associated with mental disorder, neurological disorder, and substance use disorder, the three conditions that are often closely linked and studied together. And we can see mental health impact health across the entire lifespan of an individual. And approximately 50% of the mental health condition present in adulthood begins by the age 14, and 75% of them begin by age 25, affecting adolescents and young adults as they enter school, transition into a workplace where many of the life challenges happen. What is also striking in this graph is that the peak burden of mental health and substance use issue in a general population happens among the young adult in their early 20s or 30s, and this is also the most prevalent age group that is affected by HIV reported in many, many countries. And HIV infection and mental health have a bi-directional impact due to the intersecting vulnerability. Individuals living with a mental health issue has been shown to have 4 to 10 times higher risk of HIV acquisition. Similarly, people living with HIV have consistently been reported to have a higher prevalence of mental health issue compared to the general population. So in literature, mental health and substance use and HIV, these three conditions have been described as a syndemic condition where the co-occurrence of this disorder in a population are strongly reinforced by their biological, social, and psychological interaction. For example, many people living with HIV often present with an opportunistic infection, which can lead to a long-term neurological damage, such as cryptococcal or toxoplasmosis. Stigma and discrimination, as well as socio-economic status, and it is associated with HIV and sexual orientation, might lead to stress and anxiety and financial distress. HIV medication like efavirenz are so associated with sleep disturbance and depressive symptoms. This may then lead to substance use as a way to cope with the stressor in life, and it is then associated with an increased HIV risk-taking behavior. HIV medication, this risk-taking behavior we might affect the adherence of people living with HIV on HAART or the PrEP adherence for people at risk of HIV. So in conclusion, all these conditions have been shown to have a negative impact on the individual health outcome. Now, some of you might be wondering, why would some people living with HIV do better than the others in terms of their health outcome? To answer that question, I would like to introduce a concept of determinants. Just like what it says, these factors determine how protective or vulnerable an individual is when they face challenges in life. I'm going to show you the conceptual framework that describe multi-level factors that contribute to the disproportionate burden of HIV and mental health condition among MSM, for example. At a personal level, the determinants could be questioning about your own identity, internalized belief that own identity is abnormal, or they have poor psychosocial skill. At the interpersonal level, some of the determinants could be perceived low self-esteem, poor communication skill, lack of family support. At the community level, traditions and societal norms forces people to conform to the norm and make self-acceptance very challenging. At a country level, where, like in my home country in Malaysia, where same-sex sexual activity is criminalized, there's a lot of structural barrier for the sexual minority community. And I just want to take this opportunity to highlight 3 groups of population with specific vulnerability to HIV and mental health according to the WHO recent report. Youth and adolescents are more vulnerable to HIV and mental health condition and starting to use substance, to experiment on substance simply because these coincide with their important social and developmental changes. At a personal level, it is represented by the yellow dots. At a personal level, the physical, emotional, social change that happens during that stage in life makes them more vulnerable to other risk factors in life. Intimate partner violence, unsafe family environment, trying out new substances, or being stigmatized due to gender, maybe. And the whole environment and the social legal barriers has stopped them from accessing care, which makes them more vulnerable to these 3 conditions. And I have to mention, suicide is the 4th leading cause of death among young people aged 15 to 29 worldwide. Adolescents who identify themselves as the LGBTQ community are more likely to die by suicide than their non-LGBTQ peer. Another group that's specifically vulnerable to HIV and mental health is the aging and older population, including those living with HIV. This aging population generally experience a higher rate of social isolation, reduced social participation and engagement, and another stressors such as the declining health, loss of loved ones, stigmatized and discrimination affects them as well. Accelerated aging among people living with HIV put them at a higher risk of NCDs, including mental health issues. Lastly, the key populations such as, like I said, gender minority, sex workers, people who inject drugs, often loneliness affects them, and the social isolation happens to them as well. As you can see in this diagram, Different population could get affected by the same determinants, but in their own different way. Risks can manifest themselves at all stages in life, but those that occur during developmental sensitive period are particularly damaging to the individual. For example, school bullying is a leading risk factor for mental health outcome. On the positive side, protective factors similarly happens throughout our life, and it helps us to strengthen our resilience. These protective factors include very good social and emotional skills, attributes such as positive social interaction, quality education, a decent job, or a safe neighborhood keeps people in a safer environment. Each single risk or protective factors has only limited predictive strength in the mental health outcome. Most people do not develop a mental health condition despite exposure to a single risk factor. But many people with no known risk factor, they still develop mental health condition. So ultimately, the interacting effect of these determinants remains very complex. So hopefully by now, you're more convinced that mental health care is essential for people living with HIV or at risk of HIV. The next question is, how do we do it? In this table, it shows some of the mental health screening tools that has been used in the population for different conditions. As you can see, there are many of them, but these are not all of them. Just a little bit, a small percentage of what is available out there. We have to, these are some of the consideration to make if we were to select an assessment tool for mental health for our clinical setting. Number one, these tools should assess psychiatric disorder according to the DSM or ICD classification. And we also have to be mindful that most of the assessment assess specific disorder or related symptoms such as PHQ-9 for depression, but some provide a general symptoms assessment. Some tools assess behavior related to mental health issues such as substance use or suicidal ideation. Some of the tools can be executed by a lay provider, a non-mental health trained healthcare provider, but some you have to have a psychiatrist to administer the tool. And in our resources limited country, it's always about cost. Is that a free tool that we can use for screening in clinic, or we have to pay for the subscription of the usage? And lastly, I think a lot of us are doing research in a clinical setting. We also have to be very mindful of whether the tool is too lengthy to be implemented as a clinical tool. Is it a more suitable tool to be used in a research setting? So despite the availability of multiple screening tools, in reality, there is still a significant gap in the practice of screening and management of mental health among people living with HIV. In this survey conducted in the IDEA site assessing the practice of screening and treatment for mental health and substance use in the HIV clinic, we see a low and inconsistent rate of screening and treatment across the region for various disorders. And this is a reality for most of our setting, where the median number of mental health workers per 100,000 population are extremely low at 1.5 and 3.8 mental health worker to 100,000 population for low and lower middle income country respectively. And from the same report from WHO, they have done analysis on the national insurance coverage for mental health. Only 30% of the low-income country has included mental health as part of the national insurance coverage plan. This remains a huge plan for mental health coverage under the insurance, national insurance for this country. From the same report, 60% of the low-income country, people from this country has to pay 80% to 100% completely for their mental health care. Again, we see the similar trend where the lower income countries has a bigger gap in payment for mental health care, meaning more of them has to pay for the cost for mental health. Similar trend we can see for the payment, specifically for psychotropic medication, with only about 30% of the low-income country got it covered under the National Health Program. And despite, I think for the people who work in the ID field, I would like to think we are the optimistic in the field. So despite the lack of mental health workforce and finance stress due to the mental health care, some studies has been done to understand how can we implement mental health care as part of routine care. A systematic review on the intervention and approaches to integrate HIV and mental health services help us to summarize it to the different model and different level of integration. As you can see, the single facility integration is what we know as one-stop shopping, where you get a multidisciplinary providers for HIV, mental health, substance use to be at the same facility where internal referral system facilitate that process. Often there's some level of care coordination happens in this kind of integration. If that is not possible, a multi-facility integration model can be employed, where the primary HIV team work with a collaborating agency or network of providers that is located at another facility, and often in this kind of settings, some low-intensity intervention will be provided on-site, and for off-site referral to specialized care has to be done because it is not within the same facility. And again, same level of care coordination should happen between the parties from different facility. The integration through a care coordination involves the use of a non-physician, such as a nurse, social worker, or even a peer navigator, act as a case manager who's responsible for developing the integrated treatment, care plan, and facilitate the referral for the patient. While studies from the LMIC is limited, there are available evidence shows that task shifting mechanism may be feasible and beneficial through the use of less specialized personnel such as paramedics, medical assistants, who can be trained in detecting, screening, or even managing low-intensity intervention under the supervision of mental health professionals. So far we learned a few strategies in integrating mental health care in a HIV setting. Task shifting, meaning training a non-specialized healthcare provider to deliver mental health care, low-intensity mental health care. This may actually also involve the community health worker or even lay providers like the HIV peer support that we have from the NGOs. This approach in delivering the mental health care has been shown to be effective and cost-effective. Model in which task shifting may be used include a step care model where the non-specialized staff is tasked to perform the screening and provide, like I say, low-intensity interventions such as brief intervention, and then only refer the complicated cases to trained specialists. Transdiagnostic approach recognizes that individuals do not present just with just one mental health issue, and often multiple problems co-occur. This screening strategy can potentially help individuals with mixed symptoms go through a simpler screening process and subsequently link to care based on the severity. Finally, an innovative approach can be used to support a range of mental health care delivery activity, from simplifying the screening process, delivery of treatment online and offline, facilitating training for non-healthcare provider, and also enhancing the care coordination that helps patient journey a little bit easier. And in consideration, the strategy to integrate mental health care, we need to know that there's really no one-size-fits-all approach. We need to consider the human and the structural capacity that we have on site and experiment with this strategy. We also need more data, I think, in the region that actually can showcase what what has worked in our setting, what has not worked so well, for us to learn from each other and try out our own strategy. So I'm just going to close my talk with sharing some of the effort that me and my team in the ID unit UMC has put together, trying to integrate the mental health care in our clinic. We started the ID Wellness Clinic, where it is led by a HIV nurse educator and a psychologist in May 2024. The clinic runs 2 days a week on a day that it coincides with the ID Medical Clinic. The HIV nurse educator is in charge of all the newly diagnosed clients for at least a year, and psychologists work with clients with mental health or substance use issue. And then you can see from the graph, the number of clients are actually picking up steadily. So as one of the study sites for MIN study, an implementation program funded by Treat Asia that aims to integrate mental health care in the HIV setting, we actually used a tool called EMW2 developed by the Columbia University that screened for 6 conditions with 13 questions. It was made in an electronic form where it can be done on a tablet while patient waiting to see their doctor. So those patients who were flagged from the tool, they get a referral to see a psychologist for further assessment, and we get 51% referral rate for that. And we observed that not only the appointment waiting time to meet the psychologist got lengthened, we also learned that the some of the referral that we received, they actually do not need intervention. Then we actually modify our screening process a little. We added in a further assessment as an automated process right after a positive result from the screening tool itself. This additional layer of assessment has helped us to focus our limited resources to those who have a more severe condition where intervention is more urgently needed. This intervention uptake defined by the return of patient after screening for psychotherapy was quite high at 82% of those who received referral to see a psychologist. So moving forward, what we're gonna try to do is we're gonna train the HIV nurse on low intensity mental health care, and also the possibility of engaging community members to facilitate the screening process. So I would like to thank these people who have helped me in preparing the slides and the work that I'm doing in UMC. Thank you.